Good evening, all. I hope you can hear me. Please just let me know. I would like to welcome you to our second webinar this year. I'm your host, Caroline, and today we have another important topic that will be discussed. This time we have more additional IVF lab techniques and whether they can boost success rates. With us, we have today Dr. Yadira Pallás Gálvez, who's an experienced embryologist from Vistahermosa Clinic, which is located in Alicante, Spain. And let me again remind you that the presentation will take up to 30 minutes and our live Q&A session will begin afterwards. All your questions will be published. You can type them in our chat section, and of course Dr. Gálvez will be able to answer them one by one. Okay, and again let me remind you that this webinar is being recorded and it will be available on our site tomorrow, and you can find the link to the webinar in our chat section as well. And I guess we can start. Can you hear us, Dr. Yadira?
Yes, hello everybody.
Perfect. All right, perfect. Go
Is
ahead.
that? Okay, thank you. We are talking about additional techniques that we can use to improve our results in assisted reproduction. We are going to review which is the procedure for an IVF or an ICSA treatment and which are the various techniques we can implement in order to improve the process and the results. Which are the basic procedure for an IVF treatment? Once we have your appointment with the gynecologist, including of tests and medical history, the first step will consist of the ovarian stimulation. Ovarian stimulation can last around 10 to 15 days. The objective is to increase the number of mature eggs than the ovarian produce. This means we will have more eggs to be fertilized and so far a greater choice of embryos to use in our treatment, which is very important for the success rate. Ovarian is then controlled by vaginal ultrasound scan to determine the optimal moment for the egg collection. One final hormone injection, 56 to 38 hours before the retrieval, will help eggs mature. Eggs are then collected during a minor procedure under sedation and can last about 10 minutes. It consists of a needle that passes into the vagina and into each of the ovaries under ultrasound guidance. All seeds are retrieved together with the follicular medium and they are received by the embryologist directly in the laboratory. Once the eggs are collected, they wait in the incubator with special media until the sperm is ready. Sperm samples that are prepared in laboratory using the best sperm capacitation technique according to the quality. Sperm concentration and motility will determine if an IVF is possible or if an ICSI procedure is necessary. When the quality of the samples enables an IVF procedure, all seeds keep their cumulus and corona cells and are incubated with the right concentration of a sperm sample. They then stay in the incubator waiting for the fertilization to be done, and the day after, all seeds are denuded and we will check by microscopy to find out the number of all seeds correctly fertilized. On the contrary, when the quality of the sample is not so good, we carry out a microinjection. All seeds are denuded first by enzymatic and mechanical treatment before the intracytoplasmic sperm injection. One select spermatozoa is directly introduced in the oocyte. They stay in culture at least 18-20 hours more or less until the first site of the fertilization, and then we are able to determine if insemination is correct. We have already our embryos. They will be observed in the laboratory every day until the transfer, and they are classified according to their morphology. At the end of 5-day culture, the beta embryos Sorry. Ok. Ah, ¿sabes lo que es que le da a la cámara? ¿No le da a la cámara? Okay, sorry. At the end of 5 days culture, the beta embryos are supposed to reach the state of blastocyst. We will choose the ones with the beta morphology and development to be transferred and frozen. Some of the embryos can become blocked during their development or can present some morphology alterations, so they will be discarded. Following this procedure, embryos are transferred into the uterus. This is a very simple and painless procedure, which does not require sedation. The transfer is done with a catheter that is inserted into the vagina, guided by ultrasound scan. The number of embryos transferred during this step will depend on your desire and the medical advice. The most common transfer is between 1 and 2 embryos. Spanish law allows the transfer of 3 embryos, but this is not a common practice. Results in this case can go from a 37% pregnancy rate for an IVF procedure when patients aging about 40 years old to a 76% pregnancy rate in ectonation cycles. The result depends mostly on the age of the oocyte, which is the main parameter to be considered. What else can be done? We can talk first about MACs. There are some additional techniques that we can use to improve our results, always under medical prescription. Regarding sperm selection, it is necessary to introduce MACs, which is called annexing column selection. We need to know that traditional sperm selection methods like density gradients or trimming up technique make it possible to select the spermatozoa with greater motility. Annexing columns, however, responds to the need to select between mobile spermatozoa and those that are alive. Genetic integrity of the spermatozoa is essential for normal embryo development. A high level of DNA fragmentation in sperm cells can negatively affect the embryo development and even provoke early miscarriage. This DNA damage is not detected by standard diagnosis methods as concentration, morphology, or motility analysis. MAX system has been designed to remove these defective spermatozoa from sperm preparation. The reason why DNA can be damaged are due to the age, to an inflammatory infection, smoking, drug use, exposure to environmental pollutants, and elevated testicular temperature. The procedure is very simple. Sperm samples are incubated in an annexing solution conjugated with an iron microparticle. The apoptotic spermatozoon will remain attached to the iron particle, and when passing the sample over a column, under the effect of the magnet, this will remain trapped in the column, while the live spermatozoon will no longer be attached. The intact living spermatozoa without DNA fragmentation pass through the column and are collected for a later use. This is ICSI or cryopreservation. Which is more interesting is that compared with the traditional DNA fragmentation test, MAX is not only a diagnosis test that informs the percentage of damaged cells. The advantage of MAX selection is that the resulting sample can be used for ICSI or cryopreservation. We will practice ICSI with a sperm sample from which the majority of the spermatozoa with DNA damage have been removed. Similar methods for morphological assessment like IMCI cannot provide a sufficient picture of the state of the DNA in the sperm nucleus. About results, we can say that several studies confirm pregnancy rates are increased when MAX is used. This use of new spermatozoa selection improves the fertilization rates along with the better development of embryos. fertilization rates can be increased with the use of MAX in about 10 to 15% when currently prescribed. This is when we are talking about male age, high level of DNA fragmentation, as we have already said, recurrent pregnancy loss, low fertilization rates, poor embryo quality, or an idiopathic sterility. What else can be done to improve our pregnancy rates? We can talk now about preconception genetic testing. Genetics opens a huge opportunity in assisted reproduction and increased chances of a healthy pregnancy. Nowadays, it is possible to genetically study both members of the couple to minimize the risk of transmission of genetic diseases. Why to perform a recessive disease panel? More than 1,300 recessive diseases has been counted. The penetrance of the recessive diseases is about 30%, and 1 to 2 couples over 100 are considered a genetical risk couple. Either of the couple can be a carrier of any disease without clinical manifestation, but it can be transmitted to the progeny. Depending on whether or not the partner is a carrier, the possibilities of inheritance are variable. We can have progeny that can be healthy. They also can be a carrier, or they can, of course, be affected. The most difficult issue is about which diseases we need to be studied. International societies have reached a kind of consensus that confirms that there are diseases with both high prevalence or high severity that can be studied and avoided by a genetic panel. It is not possible to reduce the risk to zero, not only because of technical limitation, but also because of the existence of novel mutations that make it impossible to have a 100% guarantee. But the reality is that risk can be meaningfully reduced. The genetic unit of Clínica Vistahermosa offers a wide range of panels, which goes from the 4 common illnesses to the largest one with more than 500 diseases included. Regarding the results, we can talk about compatibility when neither of the couple has a mutation in the same gene. And we can talk about incompatibility or a high-risk couple when a pathogenic mutation happens in the same gene or it is linked to X. What can we do then? What can we offer the patient then? We can perform a PGT-A, we can substitute one of the gametes, or we can do a preconceptional test. This is the solution. What other techniques we can offer? The time-lapse system. Once we have the embryos in the laboratory, we can leave to develop until day 3 or day 5 of culture, depending on the transfer day. The time-lapse culture consists of the introduction of an optical system in incubator so that we are able to study what's happening during the development. The traditional incubator has no optical system, so it is necessary to take the embryos out of the incubator every 24 hours at least, and to evaluate them at that precise moment. We annotate what is relevant at each moment, but it is obvious that removing the embryos from the incubating system implies some problems. For example, exposure to light, changes of temperature, organic volatile compound changes in the pH medium, and of course the implicit risk of human manipulation. This is how a traditional incubator works, and these are the amount of images we can get from the development of an embryo transfer in day 5. Apparently, the cleavage and the morphology in this image are correct. However, we have to be aware that we do not have all the information about the development. What are the embryos doing between the check-in times? Today we know for sure that there are phenomena in the development of the embryos that are associated with a low embryo quality and low implantation rates. When incubating in a traditional system, we have punctual information about the embryo's development, but not everything can be seen. Some examples of that can be a direct cleavage, multinucleation phenomena, cellular reversion. In 5-day culture, the system no. In 5-day culture, the system gets 700 images in a total of 7 focal planes. That means an amount of 5,000 images than we use to generate the video. In that way, we are able to observe up to the last detail of what happened during the development. The embryologist is able in that way to discriminate between apparently equivalent blastocysts according to all the phenomena and timing, which is very important in embryo quality. Some embryos can develop too fast or too slow. Sometimes abnormal division of the cells occurs and abnormalities can fall. Time-lapse imaging helps in choosing the embryos with the highest implantation potential. In our laboratory, we are familiar with almost all the time-lapse systems that exist in the market. We are now working with embryoscope system, Gary system, and EVA system. We have also had Primovision in the very beginning of the time-lapse age. It helped us to select the most suitable embryos to be transferred into the uterus to cause a pregnancy. And what are the risks of monitoring? There are no known risks associated with the monitoring. The only thing we need to do is to advise the patient that the number of embryos selected to transfer and vitrification are usually lower when using a time-lapse system. This is a very selective system, but with a great success rate. There are many studies that support the use of time-lapse system. The conclusion of many of them talk about 20% pregnancy rate increase, and our experience in laboratory endorse these numbers. We talk now about PGT-A, which is other technique we can use to improve our results. Aneuploidy is the most frequent cause of implantation failures, abortion, and congenital anomalies. We have here in the slide the aneuploidy rates for patient under 35 years old and for patient above 41 years old. As woman ages, the chance of having an aneuploidy pregnancy increases. The preimplantation genetic test is a technique that detects embryos carrying genetic anomalies before they are transferred to the maternal uterus. PGT selects healthy embryos, make it possible to have healthy progeny when parents are carrier, and improve implantation rates in IVF procedures. The goal of PGT-A is to maximize the chance of transferring only chromosomally normal embryos to achieve more pregnancies, to reduce the number of pregnancy losses, and to reduce the number of affected offspring. We can make the PGT-A in day 3 or day 5, depending on the cycle and the medical decision. This is a normal procedure for a PGT-A. We are making the biopsy on day 5. We are making the analysis, and we are transferring a single embryo to the uterus. And we can also add some other technique as assisted hatching or embryo glue. Assisted hatching is an additional technique we can use when needed. It consists of creating a minor defect in the embryo membrane to improve the implantation rate. It must allow for a better chance of the embryo to implant to the endometrium. This method is generally used in embryos that have unusual morphological characteristics, such as thick or amorphous membranes that make the implantation difficult. We can also use embryo glue in the embryo transfer. Embryo glue is an implantation promotion transfer medium. It's not glue in the literal sense, but it is enriched with everything that an embryo needs to help implantation in the womb, and so helps this process. The use of embryo glue during the embryo transfer increases the number of pregnancies and the number of children born. Independent studies show it has a positive impact on the implantation rate compared to embryos transferred without embryo. Thank you very much.
Thank you, Dr. Yadira, for the information and taking your time to join us here today. And now we'll be able to move on to the second part of our webinar, so Q&A session. I do see first question is ready, so let's have a look. It's from Doris. Are there any indications to use the embryo glue?
We think that the use of the embryo glue must be general, used all the time, because it always helps to improve rates. There is no anything that in the embryo glue that will damage the cycles. On the contrary, it always helps.
Okay. Thank you, Doris, for the question and for answering this. With us, we have Salome Lopez as well from the Vistahermosa Clinic. She will be assisting us today as well. And let me have a look. We do have, there are a few people writing right now, so let's give them a minute and wait for those questions. Bless you. Okay, no question. Yeah, sorry. There is another question from Doris. Are there any publications about embryo glue proving that it's better to use it?
Yes, exactly. That's why we use it. There is medical evidence. There is bibliography supporting the embryo glue.
All right. Thank you. Let's have a look. We do have next question from Nadine. Do you have experience with PRP?
Plasma. We don't use it at the moment because there is no medical evidence on it.
All right. Thank you. And let me have a look. Any specific add-on that you would not recommend?
Todas tienen que ir con una prescripción médica, o sea, todo ayuda siempre y cuando exista ese factor en el problema de fertilidad.
All of them are useful only when medical necessary. Okay, it doesn't work that the more you do, the better. There should be a medical prescription. There should be a factor demanding to be added that additional technique.
Okay, thank you, Daria, for question and for the answer. Salome here as well. And let me have a look. We have another question from Maxine. Hi there, we have one blastocyst day 5. This is just being frozen. Our clinic have recommended maybe doing a mite stem natural cycle in the hope to transfer a fresh on day 3 and transfer the frozen on day 5. Could this increase our chances?
Congelado y le han dicho que mejor hacer una simulación media suave para transferir procesos en día 3 y luego transferir el congelado en día 5. Esto podría incrementar las posibilidades.
Pero transfieren los dos, ¿no? Es que las dos opciones son válidas. Nosotros hacemos transferencias con ciclo natural.
Uno en día 3 y el otro en día 5.
Creo que es un ciclo. A ver, el ciclo natural en las transferencias de congelados funciona, tiene buenos resultados en principio, que no lo hacemos generalizado, y al final es una transferencia de dos embriones. Ya, entonces no es una práctica habitual en nuestro caso, no tenemos evidencia de que esto funcione mejor que la transferencia de dos en un día u otro.
We normally do not use it. We do not recommend it. We think that it's better to transfer all embryos on the same day. There's no medical evidence increasing that the chances of transferring some embryos freshly one day and depositing embryos a couple of days later. So we could not answer the question, sorry.
Mm-hmm.
In our opinion, we could transfer 2 of them on day 5.
Okay, thank you. And let me see. Yes, there is another question from Sheena. My husband has high sperm fragmentation, and we are doing egg donor using his sperm. We have achieved one employed embryo which has looked at chromosome abnormalities. Could his sperm fragmentation still cause issues with implantation or live birth?
El embrión ya está analizado genéticamente y es correcto, con lo cual el hecho de que su fragmentación sea alta se ha salvado con el estudio genético.
Sheena, think that the embryo has been already screened and the sperm fragmentation has been solved. Okay, if the embryo is aploid, it doesn't mean that there is no sperm fragmentation on it. Okay, so implantation should be good, and live birth, of course, also.
Okay, thank you. And let's see, from Michelle, I had another question. I had this scratch 3 times, but no implantation so far. Do you recommend the scratch? Okay, I can hear now. That's good to hear.
We are happy that you can hear us now. ¿Se ha hecho un scratch?
Un scratch, pues no sé si está realizado. 3. No sé qué puede decir aquí. Nosotros hacemos scratch cuando hay indicación médica. Hay ocasiones en las que no está indicado, pero que el scratch en principio se hace para ayudar a la implantación.
See, we normally do a scratch when there is medical indication. The scratch normally it helps implantation, so it depends on your doctor. If he thinks that you need it, of course you should have it.
Okay, perfect. Thank you. And let me have a look. From Dana, have you had a patient who, after many IVF failures with own eggs, had success after using an additional procedure?
Claro, con ese GPO, sí. Porque no tenemos la garantía de que las transferencias previas se hayan transferido embriones eufloides. Es un paso más.
This can happen only with PGS, okay, when you screen the embryos genetically, because probably in the previous IVFs or in the failures that you have had, the embryos, we didn't know if they were genetically normal or not. So after performing the PGS, we are sure that the embryos that we are transferred are viable, okay, have an implantation and to have a baby.
All right, thank you.
You're welcome.
Let me have a look. Yeah, we have another question. Would you recommend to use an on fresh cycle fresh embryos? I know there are clinics doing AH for every fresh embryo before the transfer.
De que nosotros no recomendamos la práctica de assisted hatching generalizada porque hay embriones que lo requieren y embriones que por sí solos tienen capacidad de implantación.
Sí. We do not recommend it to do it generally. There are some embryos which has implantation capacity, so you don't need to do any assisted hatching. And there are others where the assisted hatching needs to be done. So in those ones are the ones that where we perform the technique.
Okay, thank you for the question and for the answer. Let me see. We have another question from Sheena. What do you think about testing the lining of the womb to look at endometrium susceptibility? Can this improve chance of achieving a pregnancy?
Yeah.
Bueno, nosotros medimos el endometrio y también se hacen de receptividad endometrial, que es pues una ayuda para elegir el mejor momento para...
Yes, definitely it helps. Okay, if the womb is not ready or it's not prepared or receptive, it's very difficult to achieve a pregnancy. So all techniques to measure the womb or to measure the endometrium receptivity are quite important to be successful.
Perfect, thank you. Let's take a look. Yes, we have another question. Do you perform hormones blood test prior to transferring the embryo from egg donation?
La receptividad endometrial y el tamaño de endometrio idóneo.
We only deal with the endometrium receptivity, because it's very difficult to measure the hormones, because the hormones that you are giving are artificial. So it's very difficult to have that levels.
All right, perfect. Thank you. And let's see. There's another question. And the embryo monitoring, do you recommend the embryo monitoring for every patient? Is it really something that can help, or it's just a marketing behind, as we can have the video of our embryos while developing?
Aquí sí que realmente es nosotros consideramos que es una técnica que ayuda, no es una herramienta de marketing, es una técnica real que nos da muchísima información sobre el desarrollo de los embriones y nos ayuda a seleccionar el mejor embrión a transferir.
See, we do not consider at all a marketing issue. We think that the time lapse of the embryo monitoring is one of the most important techniques, because it gives the clinics and the laboratories a lot of information about what is happening inside of the incubators. In a normal incubator, you should remove the embryos every day to check how are they, and you miss lots of things. And when you do the embryo monitoring, you have everything recorded and you have much more information. So it helps the embryologist to decide which is the best embryo to be transferred. So not at all. We consider it quite important in a clinic to have the embryo monitoring system. Yeah, and all the patients could be benefits from it. It's not that you don't need any medical indication. It's always good to be used.
All right, perfect. Thank you for the question and again for the answer. And let me have a look. From Rebecca, we have another one. Can you avoid using ICSI process with egg donation? I have heard it can cause future problems.
El hecho de utilizar no hay ninguna evidencia de eso, no hay nada relacionado con la microinyección. Nosotros hacemos microinyección o IVF dependiendo de la calidad seminal, no de la procedencia del ovocito.
See, there's no medical evidence on that. We choose if we do ICSI or IVF depending on the quality of the sperm, but not on the source of the eggs. It helps with fertilization when necessary, and we don't have any bibliography or any medical parameters to confirm that it could cause any problems. We think that it's something that it helps with the fertilization.
Vamos a ver, semen determina si podemos hacer, tenemos que acudir a ICSI necesariamente.
Yeah, the sperm sample will determine if we need ICSI or we can do IVF.
All right, thank you. And let me see, we have another question here. Do you think testing for immune issues and NK cells is important if a lot of implantation failures have happened?
Sí que es una de los estudios que se hace cuando hay fallos de implantación y puede ayudar a determinar el origen del problema.
Yes, of course, it is important because when you have had failures or miscarriages, you should have a battery of tests. You should have a protocol of implantation failure cases. And this battery of tests, they include the immune test, the NK cells, and also others. So yes, it can give us the origin of the problem.
Okay, thank you. And from Sheena, we have another question. What do you think of PIXI? Can you explain it and its benefits for high sperm fragmentation issue?
Nosotros para el MAX es una técnica que está que ha demostrado su utilidad en casos de fragmentación muy elevada porque elimina un porcentaje muy alto de espermatozoides apoptóticos, y la microinyección a 400 aumentos ayuda a seleccionar de entre esos espermatozoides los de mejor morfología. Para nosotros es nuestra técnica de elección.
When we have a high sperm fragmentation, what we do is MAX, an X in columns. It has a lot of medical evidence and a lot of bibliography on that. That removes most of the apoptotic sperm. That means the sperm who is damaged. And after that, what we do is the ICSI. We have with a camera up to 100 and up to 400% amplified. With that, we have very good results of fertilization, mixing the MAX technique plus the ICSI and of course the spermatic capacitation.
Okay, perfect. Thank you. Okay, we have another question. How we as patients can judge the clinic based on embryo laboratory? As we all know, the lab is very important. When looking for a clinic, every clinic say is the best. Are there any factors we should take into consideration and maybe ask the clinic before choosing the right one? Any factors like number of IVF cycles per embryologist, experience, certification, etc.?
Yo creo que lo idóneo es elegir la clínica en la que uno se sienta cómodo, se sienta seguro, con buenos resultados. Y cuando una clínica funciona bien y tiene buenos resultados, el laboratorio evidentemente es un laboratorio con experiencia y con una buena praxis.
Yes, it's difficult to answer this question. When you choose a clinic, it's true that all the clinics, they tell you how good we are or how beautiful we are. It's when you choose a clinic, you need to choose a clinic with experience where you feel comfortable and with a trajectory. Okay, so with a way. Okay, not something that it has. You can talk to someone or you can talk to you trust. So when you feel comfortable, it means that the lab is having a good praxis and the lab is serious. Okay, that we don't think that's very difficult once you see the clinic and you see the team, it's not difficult to detect.
All right, perfect. Thank you for the question and again for the answer. Let me have a look. We do have a question from Veronica.
Yes.
Thanks for your presentation. You don't talk about score. Could I know your opinion briefly about that? Have you ever used it?
Nosotros no estamos utilizando Metascore. Metascore es una técnica de selección de viabilidad embrionaria. Nosotros utilizamos el Time-Lapse y nuestros resultados con la monitorización del embrión son muy buenos y estamos muy satisfechos.
So we don't use Metascore. We know it. It's an embryo isolation technique, but we use the time-lapse. In fact, we use all the 3 time-lapse. We have all of them in the clinic, the EVA, the Gary, and the embryoscope. We choose them depending on the needs of the patient, and we are having very good results with that. So we don't think Metascore could improve the results.
Okay, perfect. Thank you. At the moment, let me see. Oh, yeah, we do have another question. There are a lot of rumors about all add-on procedures in IVF lab like PICSI, AH, embryo glue, and more, and they are giving a false hope instead of a real treatment option, as I've seen on one of the HFEA presentations last year. So do you monitor in some way how much in terms of the treatment quality we can get using them? I mean the difference in success rates with or without them.
Sí, hay muchas técnicas y la aportación de cada una de ellas en las tasas, en el aumento de tasas de reproducción es cuestionable. Solo utilizamos aquellas en las que creemos y que están demostradas que mejoran los resultados y que en la práctica en nuestro laboratorio se sostienen y realmente están dando buenos resultados. No se puede seguir el ritmo de mejoras porque no todo tiene una evidencia y no todo apoya el embarazo.
Sí. You are completely right. Okay, there are a lot of techniques, and there are places where the techniques are always included in the treatments, or they want to sell you everything. As we spoke before, we use the techniques, the ones that we think that are useful for the treatment, that could improve the rates, and only when medically indicated, only when necessary. Okay, there are some techniques that are easier to be measured. There are others which are more difficult to be measured, but results may vary with the techniques, and results normally vary when you apply them when necessary.
All right. Very well. Thank you for the question again, and Dr. Yadira and Saloma for helping us out here. I do see we have some patients typing in their questions, so let's give it a minute before we can have another question. Nothing yet, but I do see they are typing, so let's wait. Okay, yep, we have another question right here. Do you have any standard procedure, like a set of diagnostics, procedures in IVF lab, etc., for patients with recurrent miscarriages?
Yes, of course, that's something more medical, but yes, we have a protocol to follow recurrent miscarriages. After having miscarriages, there are some basic things that you need to check. One is basic things to check. If none of them are positive, you need to go one step further and check other things. But yes, every clinic must have a protocol. Okay. to deal with recurrent miscarriages.
Mm-hmm. Okay, perfect. Thank you. And
Biopsia de cuerpo polar. Hacemos y es controvertida. Los otros son controvertidos. Sí, nosotros hacemos biopsia de reproductor dermo, pero hay muchos tipos de biopsia, pero estos dos son los que tienen una garantía, que se practican más habitualmente y están testeadas.
okay, can we go to the next question? All right. Okay, would you recommend polar body biopsy and in which cases?
Nosotros nos sentimos más cómodos con la biopsia de blastomia o la biopsia de reproductor dermo.
We feel much more comfortable with the blastomer biopsy or trophoctoderm biopsy because are the ones that have more warranties.
Seleccionamos dependiendo de la evolución del embrión.
We select them depending on the evolution of the embryo because the polar body biopsy has controverted results. So nowadays it's not clear if it helps or the contrary.
Okay. Thank you. Okay, for recurrent implantation failure, would you say PGS is the most important add-on? I've had 6 embryos fail to implant over 3 cycles, and I have 5 frozen embryos left. I'm 38, from Michelle.
Claro, es una garantía de transferencia. El SCP es como el último paso que podemos dar antes de hacer una transferencia sin más información.
The PGS is the guarantee before the pregnancy. Is the last step that we can perform before the embryo transfer. If you have 5 frozen embryos left, you should have it there.
Sí, sí se puede hacer en un embrión congelado.
Of course, it can be done in a frozen embryo. Sorry, that's the next question. we answered before you got the question. So
okay.
it's in the chat. Sorry.
All right. Yeah.
Sorry,
okay.
no.
That's good.
Yes, it can be done on a frozen embryo. Yes.
Perfect. All right. Let me have a look if we do have a question. Yes, we do. Of course. Let me have a look. Okay. From Amber, there was a mix-up before my transfer where my choice to use the embryo glue was not confirmed, so the embryologist said that if I wanted to use it, the embryo would have to sit in the glue for an hour and a half. I asked what she thought if I should do it. She said it would be good for the embryo for it to wait that amount of time anyway. What did she mean by that? I also chose to do assisted hatching in my clinic. IVF Spain does not believe in embryo glue, and the search I've done, and what you have mentioned shows otherwise.
Nosotros sí creemos en el uso de embryoglue. Es un medio que ayuda a la implantación y que no tiene ningún tipo de perjuicio en el embrión. El hecho de tener que estar 1 hora y media es una práctica quizá específica de ese laboratorio. Nosotros no lo hacemos así. El embrión se pone en embryoglue 10 minutos antes de la transferencia, no más.
We believe in embryo glue. We have been using it for many years. It's something that as we told you, there's medical evidence. You can look at other ways, not just as to be told, and it helps implantation. We have no idea about the fact of using it for an hour and a half. In our practice, we normally put the embryo around 10 minutes before the embryo transfer, and that's enough. It works good with good results. So I don't know how
Y en cuanto al tema del assisted hatching, nosotros no lo utilizamos de forma generalizada, depende de la morfología del embrión.
Regarding the assisted hatching, as we explained you, we don't use it as a standard. We don't use any additional technique as a standard, only when necessary and depending on the morphology of the embryo.
Okay, perfect. Thank you. Can a scratch cause issues to the lining of the womb at a later stage? From Sheena.
Not at all, because you do it on the previous cycle. You do it before the preparation cycle, so not at all.
Okay, thank you. And let me go to the next question from Doris. If we go with PGS, is the biopsy done on the 5th day or the 3rd day? If it's 5th day, are embryos frozen?
Depende realmente depende, se puede realizar tanto en día 5 como en día 10, depende de la evolución embrionaria y del criterio de los genetistas y de los embriólogos. El hecho de realizarlo en día 5 no necesariamente obliga a congelar, se puede realizar una transferencia en fresco, depende del tiempo de diagnosticar el embrión.
No. We can do it both. In fact, we do both, depending on the criteria of the embryologists and the geneticists. PGS can be done on day 3 and on day 5, and depending on the evolution of the embryos and the criteria for professionals, as I have just told you. And the fact of doing the biopsy on day 5, it doesn't mean that you need to freeze the embryo. That depends on how long the lab takes to have the results. But normally you can perfectly do a freeze transfer.
Okay, thank you. And we have another question from Amber. I had an ER mapping done in November which showed that I was pre-receptive. If this transfer phase, would I need the mapping done again? I've read that it is only valid for several months.
No, it's only for that cycle. You should normally you should have it again. If you haven't had your transfer, you should have it again. If not, if you can do it with ultrasound scans, but if you want to do through ER mapping, you need to do it again.
Okay, thank you. And let me see, from Veronica, we have another one. In your own opinion, if a couple or woman has only one blastocyst, would you recommend PGD-A?
Cuando realizamos un diagnóstico genético previo a la implantación, uno de los objetivos que se persiguen es seleccionar embriones. En caso de que solo tengamos un embrión, hay que valorar las opciones que tenemos. Ya no se trata de seleccionar el embrión, de si estamos dispuestos a transferir ese embrión asumiendo el riesgo de una alteración genética o si preferimos una garantía 100%. Realmente depende de muchas cuestiones, entre ellas la económica.
So when you do a PGS or PGD-A, one of the main points is to have a selection, to select which embryo you're going to transfer. When you have one, that selection is not naturally done. So there are many factors regarding the couple, regarding the medical history of the woman or the couple that you have. Before taking the decision, one of the parameters is to take the decision is the economic one, because it's not a cheap technique. So it's difficult a question to be answered. We would say that it would depend on the patient and on the case.
La observación y la valoración morfológica del embrión nos puede ayudar a decidir
See, to observe the embryos morphologically and the medical evaluation could help us to decide if to do it or not.
Depende del estudio que normalmente si
All right.
día 5 al día siguiente los tenemos los resultados para transferir.
Normally, also.
Sí, es la misma.
Sí, pero como no lo han puesto ahí.
Vale, vale, un 10.
No, esto ya lo tengo. Caroline, we are doing the questions that we have, and we need to finish. So if
Okay.
the patients have any question, they can let you know, and we will answer them tomorrow.
All right, we can do that. So can we just go to the last question, okay? And we will be finishing.
We can do all these three. We can do all these three.
Okay, not a problem. We can do it that way, not a problem. And of course, all the rest of the question we will be able to forward to you, and of course, you will be able to get back to the patients. Yeah.
Thanks so much.
Perfect. So how long we usually wait for the results from the laboratory for PGS?
Depende del estudio que se tenga que realizar, pero la auditoría está al día siguiente.
It depends on the study that we need to perform, but normally we have it in 1 day. In 24 hours, you should have the result.
Okay, thank you. Michelle has another one. What do you think is the best progesterone support? When I use Pessaris, my period starts day 8 in the implantation phase, but if I use Lubin, my period starts later.
Michelle, the medication, it's very personal. It depends on your case. It depends on your levels of hormones. We use different brands vaginally. We use also injections. There are some standard protocols, but not all the patients are receptive to that protocol. So we should know a little bit more about your history to recommend if you need to if you should use Lubion or any other.
All right. And let me move on to the last question for today. All right, and of course we will be finishing. And let's see it. Is ER mapping endometrium receptivity testing, is this the same thing? I had this done as a dummy cycle to determine when it is best to transfer embryo. This happened in November and I am due for my first transfer since this February. Are you saying that the testing I had done will not be valid for a future transfer?
The test that you have done, it can orientate you. Okay, the problem is that not all the cycles of a woman are the same. That's why we recommend it to do it when you are transferring the embryos. If you have to do it 2 or 3 months before, it could orientate the clinic where you are to do the embryo transfer, but normally it's better to do it at the moment because you go for a date, and we normally don't do it that way, but we don't say that it's not valid. We think that it could be useful as an orientation.
Okay, perfect. Thank you again for all your questions. We had many of them. And let me remind you that, of course, if you have any other questions, we are able to forward them to Vistahermosa team, and they will be happy to get back to you. You can send them to patient@eggdonationfriends.com, and I am sure they will be able to get back to you. And also, I would like to thank Dr. Yadira and Saloma for their time today, and of course answering all those questions. Thank you.
Thanks a lot for your attention.
Thank you. Thanks so much.
It is always a pleasure to have you here for sure. So again, let me remind you that you can join us during our next webinar next week as well, same time of course. And thank you all again. I hope you had some useful answers for you, and have a very good night. Thank you all. Good night.
Thanks. Take care. Thanks.
Thank you. Bye-bye.